Good morning. Welcome, everyone. I'm Colleen Corliss, your facilitator for today's online training on military sexual trauma. This training is organized by Swords to Plowshares, the California Coalition Against Sexual Assault, and the California Department of Veterans Affairs. On this last day of Sexual Assault Awareness Month, we hope to begin a much-needed dialogue among providers, advocates, and others around the incidents of sexual assault and harassment in the military, subsequent considerations for access to care and benefits, and treatment approaches when working with veterans who've experienced military sexual trauma, or as it's referred to by its initials, MST. Our presenters today are both from the Institute for Veteran Policy, to Plowshares, and the California Department of Veterans Affairs. We will provide a brief overview of the elements of military culture, military sexual trauma statistics, the basics, barriers, and repercussions of reporting, barriers and considerations to care, and benefits and services available to veterans. 3 continuing education units are available for MFT, LPCC, LEP, and LCSW professionals licensed in California. Participants in today's webinar can also request a certificate of completion after today's webinar. During this webinar, you may type a question to the panelists or Swords to Plowshares staff at any time. Simply type your questions in the question box on the right side of the webinar's display. At the end of the presentation, we will review the questions and comments posted and generate a discussion. Please note that this webinar is being recorded and will be archived on the Swords to Plowshares YouTube channel found at youtube.com/vets-helping-vets. You should have received copies of the PowerPoint and case studies by email, and if not, we will email them to you following the presentation. Our first panelist today, Star Lara, served nearly 12 years on active duty in the U.S. Army from 1995 to 2007, achieving the rank of Staff Sergeant, and was assigned to multiple duty stations as well as deployments that included Operation Joint Forge in Bosnia and Operation Iraqi Freedom in Iraq. Ms. Lara was awarded the Combat Action Badge and 2 Meritorious Service Medals for her service. She now serves as the Community Educator and Women Veterans Program Manager for Swords to Plowshares. Star was appointed as a commissioner on the Alameda County Veterans Affairs Commission. She serves on the advisory board of Women Veterans Connect, Inc. and the CalVet Annual Women Veterans Leadership Conference Planning Committee. Star was recently recognized by the California Department of Disabled American Veterans as the Outstanding Veteran of the Year, by the California Department of Veterans Affairs as the Woman Veteran Leader of the Year, and by the California State Senate as the Veteran of the Year. Without further delay, let's welcome Star Lara.
Good morning, and thank you all for joining us for today's training. We're going to be talking about military sexual trauma. And first and foremost, I want to point out that this is going to be a broad overview. We're going to talk about a lot of different topics, and there will be many of you who have questions wanting to know more or would like to know more information about specific topics. So again, this is just an overview, but we hope that this is the first of several trainings. So if you have any questions during the presentation, please feel free to post them in the questions box. And if there's any additional information or training you would like to receive at the end of this training, please feel free to let us know. A brief overview of Swords to Plowshares. We are a veteran service organization operating out of San Francisco, and we've been in San Francisco since 1974, providing a wide array of services for veterans. In addition to our housing, employment, training, and our legal services, we also have women veterans programs and the Institute for Veteran Policy. A little bit more about the Institute for Veteran Policy and a little piece of information that we're hoping that you'll come back to our website and find more information about facts, figures on veterans and their families. We've got a women veteran screening guide, domestic violence screening guide, and some additional publications. On our website, you'll also find an extensive self-help guide that has been put together by our legal department for organizations and individuals and advocates who are wishing to help veterans with their claims process and a lot of other legal issues. Key points that we're going to talk about today, just like Colleen said in the introduction, we're going to be talking about military experience, military training, but we're also going to be really focusing on sexual assaults in the military. We focus on During part 2, we're going to be talking much more in depth about the ABCs to reporting, evidentiary and MST claims, focus a little bit of attention on unique treatment considerations and community services. Why do people join the military? What is about military culture and the military structure that is appealing to young men and women? Many people join the military for a lot of the exact same reasons. Many join to be part of something bigger than themselves, to have access to education, the Montgomery GI Bill, the post-9/11 GI Bill. Many join for the esprit de corps, to follow that media ad, be the few, the proud, the brave, to be a part of an organization that protects and defends our nation, our safety, and our freedoms. But there are also a lot of individuals who join the military to escape the situation that they're in at home, whether it's childhood abuse, domestic violence, unemployment. So when we look at this focus, and we're focusing this presentation on sexual assault and MST, I want to talk about why some of those individuals join the military. If you join the military as someone who has experienced sexual assault as a child, experienced incest as a child, you're more likely to experience sexual assault in the military as well. So I'm not going to get too much into that at this point. It'll definitely come up later on in the presentation. The branches of the military. One thing I want to point out is that the big difference between the active duty, National Guard, and reserve components. Active duty is full-time employment, 7 days a week, 24 hours a day, 365 days a year. The National Guard and reserves are part-time employees. When they choose to join the military, they choose to join because they often have family commitments. They often join because it's an additional way to contribute, yet it's a part-time measure. However, during times of conflict, as we all know, that 1 weekend a month and 2 weekends a year often turns into an active duty commitment. If you look at the map at the bottom of the screen, you'll see areas that are highlighted in red. Those are areas across the globe where there's active operations. But that doesn't mean that those are the only places across the globe where we have individuals who are supporting operation in any of the global war on terror operations. One other thing I think that is interesting about the way this slide is developed is you'll see a lot of acronyms: GWOT, OIF, OEF, OND, OIR. The military uses a lot of acronyms. We often call it alphabet soup. And it's usually a way to really communicate efficiently with as little effort as possible. However, when you find yourself interacting with veterans, service members, you'll find that they often use a language that is unfamiliar. And so I would recommend that you learn a little bit more about some of the common acronyms that spans across the different branches, such as PCS, end of term of service, ETS. And so there's a lot of acronyms that could really make dialogue with a veteran and or service member complicated. So knowing a little bit more about the alphabet soup can make the interaction a little bit easier. Particularly Iraq, Afghanistan veterans and those who have served since September 11th. We've got many individuals who've experienced and not only been deployed, but deployed multiple times. I like to point out that when we have a comparison between the civilian population and the veteran population, that can you imagine the difference between someone who joins the military and spends 4 years on active duty with multiple deployments overseas to Iraq and Afghanistan, and someone who left high school, immediately joined college, spent the next 4 years doing the college experience, and how different that same age group is when they turn 25. National Guard and Reserves, as we talked about in a previous slide, many individuals who join the military to be in the National Guard or Reserves have a lot of responsibilities outside of the military. Not only do they have a lot of responsibilities outside the military, that often includes families. When they return from deployments and or in between their 1 week in a month and 2 weeks a year, the National Guard doesn't have access to all of the same services and benefits that an active duty component has. The reason of that is that there's not access to a base where you can get all of your needs met, whether that's medical, dental, going to the commissary, or the chaplain. National Guard and Reserve are often required to travel long distances to make it to the base or the training installation where they receive most of their programming. Often, the National Guard and Reserves seek care and services outside of the military system, and they'll seek services and care in their communities, providing the services that are relevant to their needs. One more thing about the National Guard and Reserves, particularly focusing on California. California's National Guard is the nation's largest and most frequently deployed force in the nation. Moving on to the combat experience. We're talking about lengthy deployments, multiple deployments, and no clear enemy. That also means when there's no clear enemy, there's no clear safe zone. There's not any one place in the theater of operations in Iraq or Afghanistan where someone's going to deploy with the expectation of being unexposed to any of the combat stressors. So combat stressors are all around, whether it's a convoy, being home safe on the forward operating base with the idea that the forward operating base is going to keep everyone safe. But as you can tell by the statistics, there is no safe area. When we're looking at these statistics collected between 2009 and 2013, these are all self-reports. So these are what individuals who are returning from conflicts are expressing that they have either witnessed, seen, or experienced themselves. 85% have been exposed to some type of improvised explosive devices. So if you were to think of 85% of college students, we're looking at the age range between 18 to 25. If you think of 85% of any population being exposed to the same traumatic environment, I think it's likely to see the connection between some of the other things that we'll talk about in some future slides. Myths and stereotypes, not only about veteran population, but some of the minority veteran populations. I'm going to go down to the very last one. Not all of those who have served in the military self-identify as veterans. This is most important to talk about those who received a less than honorable discharge, had a negative experience in the military, women is the largest population of the military and veteran population that do not identify as being veterans. Most transition from the military very, very well, but not all do. We look at the myths and stereotypes. We often need to also talk about the myths and stereotypes that our communities project on what they assume service members and veterans like to hear in regards to having a conversation about your military service. Many veterans do not appreciate and don't find comfort in being told, thank you for your service. Thank you for your service can mean a lot of things for a lot of different people. And so thank you for your service and a connection between those who do not identify as veterans and those who may have received a less than honorable discharge, and saying thank you for your service, particularly to those who have experienced sexual assault or sexual trauma. And we'll have some case studies a little later on that will hopefully go into that a little bit further. Identifying a veteran. The veteran population is growing and changing. We are seeing a lot more younger veterans. We see that women are the fastest growing minority population within the military, and of course the fastest growing in the veteran population. But you also see that this slide, we've got 3 individuals. One on the left-hand side, she served active duty in the Army. The 2 on the left are both National Guard who are actually in a vet center. So it's impossible to just look around and see who is and who is not a veteran. You look at our public figures as well as some of our fun-loving comedians, actors. Everywhere you look, there are people who have made the same commitments to join and to serve in the military honorably as myself and many of the other panelists today. A little bit about diversity within the veteran population. The median age is much older than most people anticipate. A lot of people think of that previous slide and think that that is the age of veterans, when in fact a majority of the veteran population are post-Vietnam. Quickly talk about LGBT. LGBT and those who were discharged under Don't Ask, Don't Tell, many of those individuals did not receive an honorable discharge, and those individuals are also at a higher risk for having experienced sexual assault in the military. Look at where veterans are, where the veteran population is the densest in California, and where services are available. You see the rich maroon color is the dense populations of veterans across the state. Southern California and the Bay Area have the largest populations. And California, is one of the states within the nation that have the largest population of veterans. Moving on to some of the combat stressors and combat-related issues. So these will focus a lot during this presentation on military sexual trauma. Just wanted to point it out here. But post-traumatic stress, traumatic brain injury, we're not going to really talk a lot about moral injury, but if that's a topic you would like to know more about, we can have another presentation focusing just on that topic. And in general, it is the idea that when you join the military with a particular moral code or beliefs that during your service have been shattered or altered. So when you, a lot of it has to do with combat and the combat experience, but moral injury is becoming much more prevalent, not only in how we treat those who are experiencing combat stress, but also how we see the effects of combat on our men and women who have deployed. When we talk about physical injuries, we've got some of the things that most people think of. We see a veteran who has an amputation, who is paralyzed, might have some other physical injuries. But there are so many other injuries that we don't really think that much about and aren't really making it into the news and the media, particularly back injuries, hearing damage, nerve damage, hip, knee, and other joint injuries. Post-traumatic stress. Post-traumatic stress is an absolutely normal response to an abnormal event. Post-traumatic stress is and can be a life-changing response to trauma. But when we're recognizing PTSD, we're going to talk a lot more about this in different segments, so we're not going to spend too much time here either. But post-traumatic stress and post-traumatic stress disorder is really connected to the underlying trauma, not the post-traumatic stress. So as you'll see that we talk a little bit about combat stressors, and then we'll talk a lot about sexual assault stressors. When we look at post-traumatic stress, There are those who develop post-traumatic stress as a response to combat trauma, and then we have those who develop post-traumatic stress as a response to sexual assault and trauma. And hopefully that will come a little bit further along. Post-traumatic stress, with treatment, most people learn to cope with the stress and live fulfilling lives. One more last point about post-traumatic stress is that post-traumatic stress and post-traumatic stress disorder, having the diagnosis doesn't make it easier or more or easier to access care. So being able to realize that the PTSD is really just about the diagnosis, not necessarily about the symptoms. Traumatic brain injury, really not going to focus much on it at all besides the information in this slide. Traumatic brain injury is the invisible wounds, like post-traumatic stress. Traumatic brain injury is the signature wound of these conflicts. And the signature wound of these conflicts because of the severe nature, and that it often relates in a lot of other issues that are invisible to most of those who have experienced traumatic brain injury. All right, at this time we are going to move on, or that's the portion just focusing on cultural competency within the military. And we'll pass it on to Megan Zottarelli, and she will take over and talk about overview and statistics.
Thank you, Star. Now we're going to turn it over to Megan Zottarelli, Senior Analyst at the Institute for Veteran Policy at Swords to Plowshares. Megan directs our research and analysis at the Institute and writes numerous publications and curricula on veterans issues. She has a long history of serving underrepresented communities in nonprofits and received her Master of Public Administration with a concentration in public policy from San Francisco State University in 2008. Welcome, Megan.
Thank you, Colleen, and thanks to the audience in advance for bearing with me as I go through some data on military sexual assault. I'm a professed data geek and can spend hours discussing data, but for purposes of this training, I'll try to go easy on you. But this data is really important for you to consider as a provider and an advocate or as a veteran. So now that you have an increased understanding of some of the elements of military culture, let me just show my screen real quick. Okay. So now that you have some of the elements of military and veteran culture, we're going to delve more directly into MST. So military sexual trauma, by definition, is a Department of Veterans Affairs term. So VA's definition comes from federal law. Military sexual trauma encompasses trauma both from sexual assault and sexual harassment, and its terminology is utilized by the VA to assess health care needs and disability claims. These are some of the parameters of military sexual assault within the MST definition, and I've heard providers, and I'm sure some of the civilian providers participating today, practice this approach with their civilian patients, but I've heard providers stress that compliance does not equal consent. Some of these definitions of sexual crimes involve sexual quid pro quo or other threats, and if, for instance, cooperation with behaviors is a condition of employment, and in this case, a perceived condition to continue to serve your country, the survivor may confuse or otherwise take on the guilt that comes from this compliance. So it's important as providers and advocates to stress this to survivors. One thing to make note of is that MST includes sexual harassment as well as sexual assault. So we'll get into military programs in a little bit, but it's important to remember when you are defining the trauma that the VA and the military essentially does it differently. As in the military, they don't use the term sexual trauma, and sexual harassment is handled by a different office than sexual assault. One important thing to note about military sexual trauma that people may not be aware is that the identity of the perpetrator does not matter. Only the identity of the service member matters. We'll get more into this concept when we discuss reporting very shortly, but for the VA's definition, the identity of the perpetrator does not matter. So it also doesn't matter whether the service member was on or off duty at the time or whether or not they were on base. So this, as you may guess, can affect how the identity of the perpetrator is defined, since if the service member is off duty and off base when the assault occurs, the perpetrator may be a civilian. If these experiences occurred while they're on active duty for training, or inactive duty training, which is authorized training performed by a member of a reserve component, they are considered by the VA to be military sexual trauma. And to put it very simply in relative terms, MST is an experience. It is not a diagnosis. This is really important for us to consider as we go through this presentation. Some veterans are asked, and hopefully not by providers or advocates, whether or not they have MST. So we need to get out of that mindset and that mislabeling. It is an experience, not a diagnosis. The Department of Defense defines military sexual assault and harassment as the following. The Uniform Code of Military Justice criminalizes rape, sexual assault, and other sexual offenses in Article 120. This is generally similar to sex offenses in the civilian sector. The UCMJ essentially governs the military. It was created by Congress in 1951, where before and since the Revolutionary War, the Army and Navy operated under laws from the British Articles of War. Just for a little history. The UCMJ includes most common law crimes such as murder, rape, theft, assault. It also contains military-specific crimes that the civilian sector does not have, such as unauthorized absence or absence without leave, or what we know as AWOL, and other order violations. And then the criteria for sexual harassment and gender discrimination, which are grouped together, is listed in the Department of Defense Directive 1350.2. So the Sexual Assault Prevention and Response Office addresses the criminal offenses of sexual assault, and they gather the data on military sexual assault. Now we notice that they do not handle intimate partner sexual assaults, sexual harassment, and they make the distinction between what they define and what the VA defines as military sexual trauma, which, as you know now, includes sexual harassment, and which is utilized to assess healthcare needs and disability claims. So, reports of military sexual assault, what you should know. In 2014, the DoD data show 5,983 total reports. Now, this is where it gets a little bit confusing. These reports, although we don't have the final aggregate of everything, these reports include the service member or service members as either the survivor or the alleged suspect. So when you're looking at this data, you need to keep in mind the complexities of it. So it's not just service member on service member crime, which included a little over half of the reports in 2013. Like I said, the 2014 data is too preliminary at this point to define the ratio. It also doesn't include civilian victim reports that involve a service member as the alleged offender, which are investigated and which are counted in the full report but not counted in this number. It also, I think, strangely, since it doesn't count civilian victims, but it will count reports of incidences occurring prior to the service member joining the military. And finally, it carries over subject dispositions and investigations from the previous year that are still open and ongoing. So the question is, does this accurately paint a picture of the prevalence of sexual crimes in the military? If you ask me, the answer is no, not really. So along comes RAND. In early 2014, SAPR asked the RAND National Defense Research Institute to conduct an independent assessment of sexual assault, sexual harassment, and gender discrimination in the military. Note that they count sexual harassment and also measured gender discrimination along with it. This assessment was last conducted internally in 2012 by SAPR. So they decided to reach out for the 2014 study. And compared to prior DoD studies, RAND took a new approach to counting individuals in the military who experienced sexual assaults, sexual harassment, or gender discrimination. So they draw upon UCMJ definitions and criteria for Article 120 crimes, and the survey measures of sexual harassment and gender discrimination, which together they refer to as sex-based military equal opportunity violations, MEO violations. They use criteria drawn directly from the DoD Directive 1350.2. Past surveys were designed to measure a climate of sexual misconduct associated with illegal behavior, but according to RAND, they state they had better precision in estimating the number of crimes and MEO violations that have occurred by defining them as such. So RAND's study included a survey of 560,000 U.S. service members, so they're able to show a representative sample from this survey. They found 20,000 service members experienced at least one sexual assault, which includes either rape, attempted rape, or other non-penetrative crimes during 2014. So in the civilian world, they say every 107 seconds another American is sexually assaulted. So if you do the math with military sexual assault, 20,000 in 2014 equates to 1 every 30 minutes, or yeah, 1 every 30 minutes. It represents 4.9% of active duty women and 1% of active duty men. So we'll get a little bit more into men and women survivors a little bit further down, but just keep that in mind. The figure also includes assaults by other service members, civilians, spouses, or others. So while SAPR doesn't include intimate partner cases, RAND does. And I don't have a lot more information on that, why they decided to choose that as part of their parameters. An estimated 26% of active duty women and 7% of active duty men experienced sexual harassment or gender discrimination in 2014. So close to 1/3 of women in the Navy and Marines experienced one of these violations. They found that in the Army, almost 1 in 12 men experienced such a violation, and in the Navy, it was 1 in 10. And they say for men, the largest source of problems are from sexually hostile work environments, not gender discrimination or sexual quid pro quo. Trend data show that reports are on the rise, which Lindsay Sin will discuss when we go over reporting. But while assaults are estimated to be lower than 2012, they are the same as 2010, according to RAND. So how much progress are we making is the question. 76% are not reporting the assault. Often they may not report until they come to providers in the community long after the assault has occurred, and most often after they leave the military, and that's something that we're going to stress throughout this presentation. RAND does believe that sexual assaults are in fact decreasing, and Lindsay will talk a little bit more about that when she goes into reporting. I'm going to go into some common characteristics of perpetrators and survivors now. Perpetrators of these sexual crimes are likely to wield control over the survivor, and they can continue to control and violate since they are most likely to be a member or superior in their unit. They can be in the survivor's chain of command, and they can outrank the survivor. For survivors, as you may guess, they feel an intense betrayal of loyalty. There's respect for service and chain of command that is essentially violated. This makes the service member question their value in service. It also creates huge dilemmas of mistrust when they simply must trust their fellow service member for the sake of unit cohesion and for the sake of their own safety and the safety of the unit, especially if they are deployed in a hostile environment. So this trauma shatters previously deeply held beliefs and social constructs. And that's something that's really important to think about because perpetrators and survivors are often akin to family members. MST is often said to be similar to familial trauma or incest trauma. And on top of all this, they simply can't quit their job or even sue their employers. They're also most likely far from friends and family at the time of the experiences, and very often the trauma occurs shortly after they join the military, so they fear being able to come forward even more. This is a huge hurdle. It's a huge problem given research identifying social support as the most consistent and best predictor of recovery after trauma. If the perpetrator is in the survivor's chain of command, it may seem impossible to report. Survivors often feel that they need to make an extremely difficult choice of either choosing their career or justice. And most survivors believe their case won't be taken seriously, or they fear retaliation and reprisal, so they're reluctant to report, and we're going to get more into that a little bit later. So essentially to them, often their professional lives depend on doing what's best to hide and essentially sweep the sexual crime under the rug or risk losing their job and their friends. Now we're going to get into men versus women survivors. So according to RAND, 4.9%, as I mentioned, 4.9% or 1 in 20 women experience at least one sexual assault in the past year, which is approximately 8,600 women. And so if you look at men, it was 1%, right? So 1% is actually 11,400 men. So while the proportion of women experiencing sexual assault is higher, the actual recent numbers for men are estimated to be higher than women, and they've shown that in previous years as well. At most, 13% of men report their assaults, whereas at least 40% of women report, and fewer men seek services for MST from the VA and other areas. Prior to Don't Ask, Don't Tell, to the repeal of Don't Ask, Don't Tell, men who survived military sexual assault may have been discharged for homosexual conduct if the perpetrator was a man. So there is the misconception that MST is a women's issue, as it's only happening to military women by military men, and it certainly has often been treated as such by the media and the military and even by providers. But this does a disservice to veteran men who've survived this trauma. Continuing this mislabeling makes it even more difficult for them to come forward and seek services. So it's something that you need to include men in your outreach and your treatment, and Amy Fairweather will go into this in more detail, but it's something that you need to consider in your treatment methods. So this is Protect Our Defenders. I was planning on closing with a clip, but we are having audio problems. But Protect Our Defenders, they're an amazing nonprofit organization that supports survivors of military sexual trauma through systemic research, policy advocacy, and serving as a conduit to care and VA claims. They have these really, really amazing vignettes of survivors telling their stories in the most impactful ways, and amplifying their voices, giving voice to their stories of survival. It's truly so incredible. So this is a short clip of Michael, who survived MST. You can view all of these on their YouTube channel, but I suggest that you do, just to get an accurate portrayal of what survivors have experienced. So I'm going to close now, and we're going to move on to reporting ABCs. Thank you.
Great, thank you, Megan. Now I'd like to introduce Lindsay Sin, who currently serves as the Deputy Secretary for Women Veterans Affairs at the California Department of Veterans Affairs. Lindsay served in the U.S. Navy from 1997 until 2005 as a cryptologic technician interpretive in the Arabic language. She completed 2 flight tours in Rota, Spain, during which time she deployed in support of Operations Northern Watch, Southern Watch, Enduring Freedom, and Iraqi Freedom, and achieved the rank of Petty Officer First Class. After separating from the Navy, Lindsay returned to Sacramento and worked as the lead certifying official for veteran services at American River College. She continued her work with veterans at Sacramento State as the Veteran Benefit Advisor and certifying official, focusing on developing programs for student veterans. She also serves as the Vice President of the Veterans Alumni Association. She and her husband, Matt, recently welcomed their first child, Maxwell. Congratulations, and welcome, Lindsay.
Well, good morning, everybody. Thank you so much for joining this very important webinar, and thank you so much to Swords to Plowshares for taking the lead in organizing this today, and to CalCASA for including many of their members in rape crisis centers throughout the state. For all of you joining us, we really appreciate that you're here. We appreciate that you care about this issue as much as those of us who are presenting today do. So I'm going to talk a little bit about reporting ABCs. This really covers some general discussions about what it is to go through the military process of reporting a sexual assault. The reason I think that's so important for all of you to know is that it gives you context when you're working with a client who is either currently going through the military reporting system of reporting a sexual assault and seeking services as a result of that experience, or for people that have gone through that system in the past, or either had a positive experience with reporting sexual assault in the military, or unfortunately more commonly a not so positive experience with that. The reason that's important is because that may directly affect how they interact with your office, how they interact with your staff. It could also affect somebody who is experiencing, who has experienced a sexual assault in the civilian context. So maybe they served in the military, they were assaulted in the military, but they're coming and seeking services through you because they actually were assaulted in the civilian world. Now they may have a distrust of the civilian process because of their experience with the military process. So all of this should hopefully give you some general context when you're working with clients. For those that are not Rape Crisis Center staff that are also on the call with us and see our veterans advocates or work with veterans, obviously this is good information for you because veterans that come into your office to file a claim for benefits, who are seeking services for mental health treatment with your office, who are seeking resources such as homeless resources, whatever it is, they may talk about this process and this system that you may be unfamiliar with, so it gives you more context as well. So this is a little bit about what we'll cover: restricted versus unrestricted reporting, reporting after military separation, some of the barriers to reporting, and some of the repercussions. And I'll actually go into a little bit of the statistics from the latest RAND survey that Megan mentioned and why that's so important to note. So to begin with, if someone is in the military, whether they are active duty military guard or serving in the National Guard or serving in the reserves, they have two options for reporting. That's restricted and unrestricted reporting, and we're going to talk about the differences. Essentially, an unrestricted report is when someone needs to file a report of sexual assault, and they do so because they want to, they're seeking services, one, to seek mental health services, physical health services, through typically through the Sexual Assault Response Coordinator's office and the Victims Advocacy offices, but they're doing so because they are wanting to bring the perpetrator to justice and actually press charges. So the main difference between unrestricted reporting and restricted reporting is whether or not the survivor wants to press charges against the perpetrator. And so in an unrestricted report, because the survivor wants to press charges against the perpetrator, that has a few additional details because it's the military. One, it means that the chain of command, the survivor's chain of command, will be notified that there is a pending sexual assault investigation. It may or may not involve local law enforcement, depending on the jurisdiction. Civilian law enforcement may be notified if the assault took place off of a military base. If it took place on a military base, it's more likely that the military police will be handling some of the investigation. It does grant the survivor access to medical care, to counseling, to victims advocacy, the support through the SARC office that provides victim advocacy, and we will cover victim advocates and SARCs in a minute. It will also allow that person to some legal, special legal counsel that is confidential so that they can know which way to go and be guided which way to go about pressing charges against the individual. And then they also have some things available to them, such as being able to transfer out of that workplace, base, command where their perpetrator is still residing. They can also get a military protective order against the perpetrator. Now, there are some limitations with unrestricted reporting. This means that the survivor can't necessarily control the amount of information being released to the chain of command. This becomes kind of a somewhat public process. As many of you know who work with civilian survivors of cases of rape and assault, very similarly, information is out there, and suddenly many people tend to get involved in this process. So the survivor, sometimes they don't feel that they can control the flow of information or the release of information when they do file an unrestricted report. Additionally, this can be a lengthy process. Obviously, there are elements of misunderstanding and discrimination in this process, in that survivors can feel blamed just as they do in the civilian context of assault. They do get questions and can be questioned at length about all of the details of their sexual life, about where they were that night or day, or prior to the incident, what they were doing. I personally know some folks that were assaulted in the military, unfortunately, and of course their sexual history was immediately kind of determined once they filed the charge of assault, and that seemed to be the focus about who else they had had a sexual experience with other than the perpetrator, and unfortunately that can continue today. Also, the chain of command, or the work environment in the military and military culture, because we work together, because we live together, it's such a tight, family-oriented community and such a team that it's very unlikely once someone's assaulted that the whole command or the whole kind of family unit of the military doesn't know, which also is something that the survivors are going to consider when they decide to file unrestricted or restricted reports. Oftentimes people note that they don't file an unrestricted report because they don't want people knowing. They don't want everybody knowing their business. They don't want everybody knowing about any other sexual experiences they may have had, because all of that is on the table, unfortunately. But this is the way with an unrestricted report that someone can press charges against the perpetrator. In a restricted report, the reason that that report is available to survivors is that the first priority of the Department of Defense is to ensure that every survivor has access to mental health care, to physical health care that they may need, and to victims advocacy, and to the support that they may need, the emotional support, if an assault occurs. So they don't want there to be a limitation for somebody who does not want to file or press charges but still needs access to that kind of care. So they've allowed a restricted reporting process because of that. This does allow somebody, as I said earlier, to gain all of access to things like health care, mental health care, the medical care they need, the counseling they need, as well as support from the sexual assault response coordinator, from a victim's advocate, from chaplains. And the chain of command is notified that a sexual assault has occurred, but they're not given any details, so they don't know who the survivor is. Additionally, law enforcement is not involved and charges are not pressed. Unfortunately, with a restricted report, this means that a person is not allowed an expedited transfer out of the workplace or base or command away from the perpetrator. They're also not allowed a military protection order. Obviously, the perpetrator is not called in for an investigation. They're not questioned, and no charges are filed. But at the very least, this person is given the option to seek all of the care that they may need. At least they get that much. The other thing with restricted reporting is that if the incident is reported, say, because the chain of command is notified, you'll see under bullet G here, we've indicated this in bold. If the chain of command is notified, some people aren't even given the option for restricted reporting. It immediately becomes an open investigation of assault. Additionally, somebody that does file a restricted report has the option later on to file an unrestricted report. So another reason that restricted reporting is made available is that this gives the survivor time to think about their options. They can decide to immediately access the care they need, and then from there decide later on if they want to file an unrestricted report. There is a time limit on that. I believe it used to be 1 year. I don't know if that's been updated, but they do need to, at some point, they'll have the option to file unrestricted, which means they can press charges. So an expedited transfer would allow someone to, if they file an unrestricted report, would allow them to be removed from the area where the perpetrator may still be. In other words, if they're in the same workplace, if they are on the same base or command, they can be removed from that area so they don't have to encounter that perpetrator again. And I think this is kind of one of the unique things about military sexual assault is that because it so often happens between two individuals that work together, that know each other, or that are at least geographically located in one place that's hard to get away from because people are assigned to bases, because they may be forward deployed together and they can't really go anywhere else. it's so often that the survivors encounter their perpetrators or can encounter their perpetrators after the assault. And that's one more thing that makes this such a unique set of traumas, as well as such an important thing to consider when counseling these individuals, because the trauma may be pretty intense because they had to encounter the perpetrator again. That happens in the civilian context, but I don't think it happens quite as often as it does with the military. So the sexual assault response coordinator, this is the person that's responsible for managing the program at the military installation in order to coordinate the victim's advocacy, the reporting structure for the individual, and liaises regularly with law enforcement if necessary, with the chain of command if necessary. And their main duties are really to provide education and prevention on the front end, to consistently maintain contact with any survivors, and to manage those specific cases for the different types of reporting. And then they also work directly with the victims' advocates and liaise with the commander, as I've mentioned. So the SARC is kind of the main point of contact for running the program on an installation regarding sexual assault in the military. Now, the Special Victims Counsel program, this was just recently implemented because it turned out that survivors of military sexual assault, once they decided to report and go forward with pressing charges, they did not have the option to gain confidential advice, legal advice, with the prosecuting officials in the military. So they really had no way to kind of decide which way they were going to go with charges, with what they wanted to release, what they didn't want to release. So Special Victims Counsel was created so that the person would have confidential legal advice. They could kind of have an advocate when it comes to the whole process of filing charges, which obviously is very lengthy and intense. And this was a really good system that was put in place just recently, and so well needed because it created a real barrier for people to file and press charges. So you can read a little bit about what they do. So covers the full scope of representation for meeting with clients, providing advice to the clients, attending interviews for them, let's see, explains questions that they may have about just the whole process in general, and protects their privacy. The victim's advocate, these are volunteers usually assigned to the command who have been trained by the SARC and who work to support the individual that may need services and support as survivors of military sexual assault. So they don't provide professional counseling or legal advice, but kind of help the person understand the process that they're going to go through, as well as provide some kind of moral and emotional support. So this is a little bit of information from the RAND survey for the 2014 reporting process, or the 2014 assaults reported. If you notice that top bar, that dark blue bar, it says that essentially 62% of individuals reported that they experienced retaliation if they had reported a sexual assault. And that is broken down between professional retaliation, social retaliation, meaning their coworkers, their peers. There's also instances of administrative actions. And then in the very bottom bar, you see 11% were punished for an infraction. This could be that the individual was perhaps drinking when they weren't supposed to be. The survivor was drinking underage. They were drinking when that had been restricted. They were not in a place that was authorized for them to be. So at some point, through the course of the investigation of the assault, if that person was essentially violating military orders or directives, then they could have been punished for an infraction as well. Now, the DoD currently says that they will wait to file those types of infractions against the survivor until after the sexual assault charges and that kind of military investigative process has taken place, but I don't know if that is as seamless as it sounds. So these are kind of some of the reasons and the barriers why people may not report their sexual assault, why this remains a highly underreported issue in the military. Because people are afraid to disrupt the unit cohesion. That would be under the social retaliation. They were retaliated against either by their chain of command directly in a very clear violation of DoD policy, or they were unofficially labeled as malingerers, which is a really popular word in the military, meaning somebody that doesn't do their job or skirts their responsibilities. They were labeled as people that were kind of whiners. They were labeled as people that had reported maybe multiple incidents of sexual assault, so they were not often believed. These are all things that I saw directly from women in particular that filed charges of sexual assault while I served in the military. Those were all things that happened to them. So social retaliation, and then just the perception that these individuals were not telling the truth or were troublemakers is a big issue, remains a big issue, because even in 2014 we're seeing that 62% of those that filed these charges of assault or reported their assaults indicated that they had some type of retaliation. We found the same thing in the statewide survey we did with women veterans here in California as well. So the reports of sexual assault, this is just comparing the 2013 survey. Obviously that survey was a little different because it wasn't done by RAND versus the 2014 survey. This is showing that the number of reports increased. So this is where DoD says this is positive, meaning that people are more likely to report now. And as Megan's previous data indicated, women and men are reporting sexual assault. They're more likely to report these days. Unfortunately, the numbers of sexual assaults hasn't decreased very significantly, and the majority of the reports still remain unreported. So disciplinary action that is reserved currently within the military's chain of command and within the Department of Defense includes that commanders are the ones that have the ultimate authority to decide what happens when charges are filed against an individual. That could be that they go through the courts-martial process. A courts-martial is a more severe form of punishment in the military under the Uniform Code of Military Justice. This is really reserved for heinous charges, such as what we would consider equivalent of misdemeanors or felonies within the military structure. And even for some lesser charges according to the UCMJ, because the UCMJ does have some pretty interesting violations in it, including adultery, including different forms of sexual acts that are perpetrated between consensual adults that are maybe a little outdated. But commanders really reserve the right to decide how that's going to go. So it can be a courts-martial. It can also be a lesser charge or a lesser punishment, depending on what the evidence is found, which could be in Article 15 in most of the military services. In the Navy, it's called a captain's mast. One thing that through this military system of adjudication with these sexual assault charges that does exist is that if somebody is, if there's not enough evidence to charge an individual either in the civilian court or the military court against a case of sexual assault, the military can charge somebody under the UCMJ with a lesser punishment. So say that person, they can charge them for conduct unbecoming of an officer or enlisted personnel. They can charge them with being in the, there's kind of a catch-all article in there that they can charge them with. So there's different things that they can actually charge the perpetrator with that don't necessarily accomplish the charge of sexual assault, but do something that maybe the civilian authorities can't do. So some argue that that is at least a successful process with the military in that somebody can be charged with and punished with other things if the charge of sexual assault or rape does not stick. About 38% of cases that were reported actually resulted in charges filed in 2014. That seems like a fairly high number, but you have to remember that the total number of assaults reported was very low. So that's still not a lot of people being charged that probably should be. Additionally, it's indicating that conviction rates have decreased a little bit from previous years. Anecdotally, I'll tell you from a friend of mine who's a victims advocate or was a victims advocate in the Navy, what she was seeing in light of all of these developments and how public the whole Department of Defense process for sexual assault has become. She was seeing that some people were, juries juries and the whole prosecutorial team, they were almost afraid to charge someone with rape in some instances because they felt that what accompanied that. So being made to be a mandatory registrant on the sex offender database, for instance, was such a severe crime that they did not want to charge the person with rape. There's been some instances where there's been such a focus on military sexual assault lately, and there's been such a kind of a fine-tooth comb taken to the whole process, and such a focus in the military branches to make sure this is something that's been prevented and highly prosecuted, that some people are kind of reacting to that in an unknown way. And the reaction has been to almost not charge people, or to not take a case and elevate it to a charge of rape if they can kind of squeak it into an issue of non-consent or something. That's unfortunate, because obviously in the civilian context we believe that yes means yes and no means no. So consent not given is still constitutes rape, but this is taken a different context in the military. Additionally, if the issue occurred, if the assault occurred off of a military base, then jurisdiction may be given to civilian authorities. Local law enforcement may be involved to collect evidence for the crime scene, etc. And that may result in prosecution in the civilian context. Sometimes the civilian authorities have been known to not be able to find any evidence that can make a charge stick, and therefore may bring it back to the military jurisdiction, and in that case the military may decide to charge the individual through the UCMJ. So we have a case study. What we want to highlight here is that rape crisis centers are actually receiving clients that are either veterans of the military or active duty military, and are therefore dealing with sexual assault either in their past or having sexual assault occurred in the military or after they get out of the military. So I'm going to read through this case study, and then Star Lara is going to go ahead and introduce a poll to you that you can take online through this webinar software, and then we can discuss it a little bit. So I'll read through this briefly. So this is a case study from Verity. They had a caller named Carla, and Carla said she was a veteran. When the crisis line counselor spoke with her, the first thing they did was thank her for her service. Carla immediately, there's a typo in there, but Carla immediately becomes slightly combative when she hears this, and then states that she was diagnosed with personality disorder and was forced to leave the military with less than honorable discharge. This does happen. And Carla says that she was raped while she was in the military on different occasions and suffered childhood sex abuse. Now, the reason that this is an important case study is because this is a true incident. This is something that we have seen regularly where people are discharged with personality disorders, and the reason they were discharged with that is because they were experiencing PTSD or trauma related to having been assaulted or raped in the military. It is also common to see a survivor having been assaulted by people that outrank her in the military, and for survivors to have had some sort of sex abuse in their past prior to joining. So with that, I'll turn this over to Star to conduct the poll.
Thank you, Lindsay. We're turning it back to Star Lara, who will go over some of the impacts of MST. Welcome back, Star.
Thank you, Colleen, and thank you, Lindsay. The poll question: why did Carla become combative when the CLC thanked her for her service? Option A, it triggers the trauma she experienced. B, she feels like the CLC didn't understand her experience, or she feels that people are disingenuous when they say it. Option D, all of the above. So we'll go ahead and continue the poll questions for just a couple more moments while the audience has an opportunity to respond. All right, about half of you have answered. So we've got 13% saying option A, and majority saying 78% was option D, all of the above, that it triggers the trauma she experienced and that she feels like the person doesn't understand her, and she also feels that they are being disingenuous. All right, we'll go ahead and turn it back over to Lindsay.
Okay, so thanks so much for taking that poll, folks. Exactly. Carla could have been experiencing all of those emotions at once. So all of those answers are correct, but we put D, all of the above, in there because obviously any one of those could be accurate. She may not feel that the counselor is really understanding her experience. She has many residual feelings and emotions about how she was forced out of the military, and that's where cultural competency really comes in, being sensitive with the caller or the client and understanding perhaps that they may not be as proud of, well, they may not be as okay with what happened to them in the military, although usually proud of their military service. What happened to them as a result of that assault has deeply affected them emotionally and may come up in the course of treatment. We have a second case study that we'd like to do as well, and this comes from the Project Her. Client A was a woman, active duty member of the military. She was in the service for 20 years. She was connected to the services that she sought through the center because she had been molested as a child and was assaulted by an acquaintance. When she went to get help, she was not given the support she needed. Later on, she was assaulted by a civilian and knew that she needed more services, so she sought those out on her own, was connected with Project Her, and that consisted of counseling, support groups, and workshops, and she was an active participant and very involved with the agency. So you may find somebody that served in the military, maybe they didn't experience an assault in the military, but because of what happened to them either prior to or after serving, they are seeking services. This is an individual that really may need to connect with services outside of a rape crisis center, for instance, with the U.S. Department of Veterans Affairs or with the State Department of Veterans Affairs, our agency, so that they can be connected with benefits. One thing that I think is always good to offer when you're working with veterans is obviously we ask, have you ever served in the military, as opposed to, are you a veteran? Because not, as Star mentioned earlier, many people don't internalize that label of veteran. Additionally, they may want to be connected with services as a result of their service, but may not even know where to go, or they may not know that they're eligible. We find that many, many folks don't know they're eligible for benefits. And so I'd encourage all of you to offer that up and use your resources, use your contacts that you'll get from this webinar and other sources of training to refer them to how they can get connected with USDVA and state benefits and resources such as disability compensation, retirement pensions, health care. All of that may be available to these clients. So with that, I think I'm turning this back over to Star or perhaps Colleen. So on with the presentation.
Thank you again, Lindsay. Give me just 1 second. All right, we are going to move on to issues relating to MST. Again, I want to reiterate that when we're talking about MST, we're talking about the experience or the stressor, not the diagnosis. Some of the common overlapping symptoms and or issues relating to the response after being sexually assaulted. So many people who are sexually assaulted experience a lot of different symptoms that make it difficult to transition and to function normally into civilian life. These symptoms aren't necessarily restricted just to those who have served in the military, but a lot of these symptoms are for regular people who have experienced sexual assault and trauma. Many of these make it difficult for particularly those who have served in the military to make, gain, and retain relationships not only with friends, family, and loved ones, those that were supporters prior to joining the military, but maybe even spouse and children that were there before and after the assault. So these really strong emotional reactions and reminders and all of the other symptoms can make it very difficult for a survivor to engage and re-engage. They may seem disengaged, flat, emotionless. And as a result of sexual assault, we talked a little bit earlier, and Megan talked about it as well. We talk about incest and having been repeatedly sexually assaulted, whether that is taken into consideration being sexually assaulted prior to the military, being sexually assaulted in the military, and then again, a lot of individuals who were sexually assaulted in the military find that they've been sexually assaulted after the military as well. These symptoms have a very strong impact, and the reason that these symptoms can have such strong impact for those who were in the military is the very last bullet. Difficulty with hierarchical environments. Relationships within the military, that structure, that chain of command, that camaraderie that Lindsay and Megan both really touched on, make it really difficult when compared to what we have this assumption that these are our buddies, our battle buddies, our comrades. I'm prepared to give my life, and I have the expectation that they are prepared to give their lives for me as well. The chain of command is often associated with a feeling of lack of support after the event. Looking at mental health diagnosis, women are much more likely to be diagnosed with any of the other disorders as opposed to PTSD as a result of sexual assault. Many will receive treatment for the symptoms associated such as depression, anxiety. Oftentimes it's anxiety disorders compounded with bipolar disorders. What we see is that those who have experienced sexual assault in the military often report a lot of different mental health conditions and are diagnosed with many different diagnoses. So we're looking at mental health issues and how they are correlated, how there's the comorbidity, how there's the overlapping symptoms, and how it's not just one thing, but how there's usually this onion of issues that make it very difficult to identify what is the most pressing of those issues and what needs the most attention, and how to treat someone with a lot of these issues. The disconnection, we'll move back. The dissociative disorder, which is the disconnection between thoughts, identity, consciousness, and memory, usually develops as a way to cope with trauma. The somatization is, really just not understanding the symptoms or how you are supposed to respond in our society to these issues. That, as Megan and Lindsay were talking about, that you often receive retaliation. Many people just don't understand why you would report or why you would break up the unit cohesiveness in the organization. Like other major life stressors, we find that there's often a negative correlation between that and health outcomes. So the overall related health outcomes for those who have experienced sexual assault is negative. So we talk about all of the issues and inability to cope and inability, and many times those not seeking services, not only undiagnosed but untreated, not knowing what their resources are, like Lindsay had mentioned, not knowing where to go, not thinking that there's anyone out there to help them. Oftentimes, those who have been sexually assaulted in the military end up as part of our homeless population. So those who have experienced sexual assault We look at our population in Swords to Plowshares and within our housing programs, particularly our transitional housing and our permanent supportive housing for those who have been chronically homeless and or are our aging veteran population. It is way over 50% of those that report that they have been sexually assaulted, and that's specific to our women veteran population in our housing programs. Moving on to barriers to meeting those needs. One of the things that Lindsay mentioned is that if you don't acknowledge and identify with the word veteran, then you're less likely to seek veteran services. You're less likely to go to the Veterans Administration, apply, seek out benefits, either whether it's through the Healthcare Administration or through claims and compensation and pension through the Benefits Administration. Many veterans know that they are entitled to education benefits, but a lot of the other benefits many just aren't aware of. They're not sure where to go, and you, the civilian providers, may be that very first link. When we're also talking about VA services, we didn't talk about too much anywhere else, so I'm just going to mention it, that accessing VA healthcare and identifying with being a veteran is usually connected with whether you are considered and or eligible by the Department of Veteran Affairs. And we talked about a little bit at the very beginning what your discharge type might be, whether it's an honorable, less than honorable, and it also came up again in our case study. Many survivors of sexual assault are even more unlikely to use the system of care offered by the Veterans Administration. It reminds them of that hierarchy. It reminds them of the system that not only didn't support them, but it also didn't protect them from the assault or give them the care and attention that they needed after the assault. Barriers to meeting those needs for women. As Lindsay mentioned, there was a survey that went out to all of California residents to really try to identify and focus on the barriers, what women needed, what they knew about, what their services were, but also what their experiences were. Women who don't identify as being a veteran, again, are less likely to use the VA, but that means they are more likely to seek services outside of the VA and in a system of care that hopefully we are beginning to bridge the gap so that those providing care and services to veterans and those who have experienced sexual assaults will have more access to a continuum of care. So when surveyed, the main challenges that were reported, and as we're talking about women not identifying as veterans, the second bullet really speaks to that. Many women also do not identify as being a veteran because they just don't feel like they get the respect and the acknowledgement, not only for their commitment to the country, but for their actual military experiences, whether those are positive and or negative. All right, how can any of this information help you target, build support, and provide an environment for the veterans that you are likely to encounter, provide services to? And one way is it begins with the conversation. How do you build a rapport? You say, welcome home. How may I help you? Factual questions, and most important, connecting them to the resources that are within your purview. Knowing what resources are outside of your organization that someone has access to. Because the more resources, the more likely they are to find the resource that is a good fit. I know it's going to seem a little silly to point out to this audience, but you would really be surprised how many times we hear very judging, judgmental, and insensitive questions. What not to say. Middle of the slide, do you have MST? Again, as Megan pointed out earlier, you don't have MST. MST is the experience. You having experienced sexual assault. But again, it's something that we hear a lot. I have been personally asked this, and it's an absolute do not say. But what do you say? Tell me a little bit more about your experience. Why did you join the military? Start with questions that lead into opportunities to have real dialogue and discussion. Ask open-ended questions. And when you're wondering how you're going to ask the questions that are relevant to identifying what their real experiences were, given an opportunity to tell my story, I will tell you all the things that you need to know. Doing so, you'll likely have all of those lingering questions about any underlying issues and or trauma will likely be answered. Judging and polarizing questions are counterintuitive to creating an environment of comfort, support, and encouragement. And at this time, we'll turn it back over to Colleen for the next section of the presentation.
Thanks once again, Star. Now I'd like to introduce Linda Bonoy, Claims Representative for the California Department of Veterans Affairs. Linda served in the U.S. Navy between 1973 and 1984. After leaving the Navy, Linda worked for the federal government in San Diego at the Border for Customs, now known as Homeland Security and National Civilian Community Corps. Linda worked for several nonprofit organizations in San Diego and Los Angeles before working for the federal government in 2006 at the Department of Veterans Affairs as the Veterans Service Representative and as Women Veteran Coordinator for the LA Regional Office. She now works for the California Department of Veterans Affairs as a member of the LA-based strike team, addressing the backlog of claims for California veterans. Linda continues to advocate for her fellow women veterans and provides guidance on claim filing and working with veteran men and women with MST claims. Welcome, Linda.
Thanks, Colleen. Good morning. I'm going to continue the dialogue here on military sexual trauma, also known as MST, and because of the personal nature and sensitive nature of the event, the stressors a lot of times people are not aware of, so we're going to look at that for a moment. The stressors are not always evident. The available stressors are usually very insufficient on its surface, so that's why you have to dig a little bit deeper. Now, July 12, 2010, the VA developed regulations and procedures that were a little more liberal to grant PTSD due to MST to survivors of the assault, and that's for both men and women. Now, service connection for PTSD, whether it's for sexual assault, combat, or otherwise, you have to have a diagnosis, medical evidence diagnosing the condition. There must be a link established, of course, with medical evidence, symptoms, and in-service stressors, and credible supporting evidence that the stressor or the claim incident did happen in service. And that is supported by the Regulation 38 CFR 3.304F. PTSD claims based upon personal assault. And this is an occurrence that happened in service. And a lot of times, because these do go unreported, the veteran's lay statement alone, coupled with some evidence that we can look for in their military service files, that alone, just the statement alone indicating that they have been sexually assaulted or there was domestic battery, or et cetera, while in service is one way that they can establish the claim, and they can also, that will garner them to be able to get a veteran's VA exam so we can establish that this did happen in service. Now, rather than the usual documentation, we have to look at other sources. The VA exam usually encompasses a medical opinion, and that is where the evidence or markers are found. And I'll go into markers in just a moment. And we look for those markers in their service record and their post-service records to see if we can find those stressors, because 9 times out of 10, the event is not reported for the reasons we've already discussed today. Based upon the fact that MST survivors don't document what happened, okay, a lot of times what will happen too is that they will not report or even come in for benefits or services until sometimes 30, 40, and 50 years later. So it's very important that we key in on the fact to look for markers that happen either in service or post-service. As a result, the evidence that we seek must be sought indirectly, secondarily, or circumstantial. Now, the statutory definition is this is psychological trauma, which in the judgment of a mental health professional employed by the department resulted from physical assault of a sexual nature, battery of a sexual nature, or sexual harassment, which occurred while serving on active duty or active duty for training. And included under the MST umbrella is sexual harassment, which is Department of Veteran Affairs defines it as repeated, unsolicited verbal or physical contact of a sexual nature which is threatening in character. Now, we're going to talk about the markers and the PTSD exams. Markers refers to evidentiary signs, events, or circumstances that there's possibly something did happen. And these are going to be established by Section 3.304F5 of the CFR, 38 CFR. And these include looking at the records, all records, whether they're service records or records that have been brought in after they left service. One of the big things that we look for is behavior changes during service or at some credible time following service. Because you can have an individual, and I being a Navy person, a sailor, I'll use that term, you can have what we call a 4-0 sailor. And the event happens, and all of a sudden then their performance goes down. That is a clear indication that the behavior has changed and something has happened. Now, some of the other markers that we look at are, and these are sources and records that we can get from these sources, we can go to law enforcement authorities. A lot of times, in my experience when I was the women's coordinator, my experience, the ones that were reported were the ones that were of violent nature. So, and those are the ones where you can get the law enforcement authorities to give you the report from that particular event. Some women and men do go to the rape crisis centers and ask for help or treatment even while they're on active duty. Of course, mental health counseling, hospitals, physicians, pregnancy tests, because sometimes out of rape comes a pregnancy, and out of that pregnancy is a birth, or out of that pregnancy is an abortion. So these are the things that you will look for. And also look for sexually transmitted diseases. Now, when in absence of documentation that the event happened, what I often advise people to do is, if they told anyone about the event when it happened or shortly after it happened, to get these statements from family members, roommates, fellow service members, clergy, anyone that they told, because this is going to help establish and substantiate their claim. One of the other things that, some of the other things that we look for, and these of course are not limited to just what you see on the screen, but these are some of the things that are kind of obvious, like a request for transfer to another department, or just to leave the area and go to another station. As I've spoken before, deterioration in work performance. Substance abuse is a biggie. A lot of times you will see that they would turn to alcohol and drugs to escape because they're so ashamed as to what has happened. You have episodes of depression, panic attacks, anxiety without any identifiable cause. And of course, you may have some unexplained economic or social behavior changes as well. Now, under the behavior changes, performance evaluations will usually decline. Now, there is some incidents, and as bullet number 3 states, there are some rare cases where instead of your behavior declining, the person goes overboard. That's where they become overachievers. So those do happen, but they are rare, and that's what we call the overcompensation reaction. Behavior changes occurring after service can also constitute some markers, and those are usually, if you dig deep enough, those markers can also be related back to what happened in service, and if you look closely enough, they usually correlate with each other. The private medical record showing treatment for mental disorders after service will be a good indication, especially when it's immediately following the service. Emotional reactions resulting as a result from the in-service MST, even though there is no documentation, but the behaviors are still there, especially symptoms of PTSD. Late statements that are produced years after the claim stressor, if the late statement does not relate to anything, to a credible event, then those late statements may not be considered. It's a possibility they can, but it's a good possibility they won't. So you have to really tell the person when you're looking for your late statements, only get your late statements from people who you have told about the event, because those are the people who can best testify in your behalf. Because if they knew you prior to the event and they know you after the event and saw changes in behavior or some of the things that you did afterwards, they can write good late statements for you, and those late statements can help make or break a claim for service connection. And as with all cases, these late statements are going to be evaluated on a case-by-case basis, and it's going to be viewed in light of what the other evidence shows as well. And now I'll turn it back over to Colleen.
Thank you, Linda. Now I'd like to introduce Amy Fairweather, Director of Swords to Plowshares Institute for Veteran Policy, which conducts public policy research regarding veterans' health, access to benefits, and socioeconomic well-being. The Institute for Veteran Policy also delivers technical assistance to veterans serving nonprofits and community education, such as today's webinar. She has worked in the field of public health policy, in particular with and on behalf of trauma survivors, since 1999. She received her undergraduate degree from Mills College and her JD from the Hastings College of Law. Amy is a member of the State Bar of California. Welcome, Amy. Hi folks, this is Colleen again. It seems as though Amy is having a connection issue with her microphone. If you can bear with us for just 1 minute. Thanks very much.
Can you?
You're here, Amy.
Can you hear me? Okay.
Yep, your Colleen's just.
Okay, am I here?
You are here.
Okay. Sorry about that, everyone. So I'm going to talk a little bit about the public health approach. As we've discussed, many veterans are reticent to use veteran or military-specific services, whether that's because of their experiences during service, they're being survivors of rape or trauma. In other cases, they're simply not eligible because of their discharge status, or they may just have, health insurance through their employer, and so they're using HMOs or Kaiser or anything out there in the community. So it's important for us to make sure that people have the cultural competence and they understand in the broader public health world about these issues. And so talking about veteran-specific services, women, domestic violence, interpersonal violence, rape crisis, veteran men who will need services. And we look in the community, we, in addition to our direct services here at Swords, we have done some re-granting and technical assistance around the state of California and indeed the country. A lot of that work is with non-veteran specific groups, and we know that we have to meet the veterans where they are, whether that's in employment services, housing services, legal aid, and indeed, perhaps many veterans are more likely to come forward with those issues that they really need help with in these alternate venues rather than through traditional military or veteran-specific services. So in our work, and I'm assuming that many of the people who are listening now, some may be working for the military, some working for the VA, others working in the community, private practice, community-based clinics. And when we've worked with these organizations throughout the state and the country, we know that we're still having barriers, and we all need to work harder to overcome them. One of the main issues that many of our grantees had is the degree to which they really needed to ramp up and get that cultural competency and training for their staff. The other barriers they were having were assumptions about the availability and access of VA care. Again, people may not go, they may not want to go, they may be ineligible to go. It may be an unhealthy atmosphere for them. It may be a geographical issue, or it may just be the ease with which they're using the community resources, particularly if they don't really identify primarily as a veteran, but identify as a woman or a husband or a daughter or a wife or a mother, rather than the word veteran. Another thing, and being a veterans organization, we have to acknowledge this, is that many veteran organizations, many military organizations are insular. These are our veterans, these are our military, we know how to take care of them and no one else does. I don't think that this is limited to veteran and military organizations. I think other specialty care, we serve children, we know children, other people don't know children. We know rape crisis, other people don't know it. So and there are good reasons for that, because we do know more about our cohort than others, and we can't do everything. But I think it goes to the notion that we need to talk to each other more, and we need to share the burden and do what we can and provide a community of care. Other of the barriers were attitudes requiring women's services and military sexual trauma, which include, should women be in the military, should they be in combat, and others that unfortunately have been culturally traditional in our culture about they shouldn't have been there in the first place, and those sorts of very unhelpful attitudes. And the attitudes regarding men and military sexual trauma. Are they homosexual? Is that weak? And again, some of those very unhelpful attitudes and stereotypes about gender and sexual assault. So as we look at the challenges in serving women veterans with military sexual trauma or other things, again, we've talked about it several times, the reluctance to seek care, the tendency not to self-identify, previous negative experiences, lack of gender-appropriate care. We go down to the bottom and with Section B, attrition, our grantees throughout the state had a lot of women veterans drop off from services. We can't be sure with any certainty why that's happening, but we know that there are some very basic pragmatic issues with competing obligations, families, a feeling that they have to take care of everyone around them before they take care of themselves, certainly financial issues, transportation, but this is something that we need to address in order to improve our services overall in the community system of care. The other being very high acuity. Many women will not seek services until there is absolutely nothing else to do. And then not only is the high acuity with their mental and physical health, but the other aspects of life that, that fall off, housing stability, economic stability, so on and so forth. So very challenging. So we go over to men who have experienced MST. The first one is exactly the same as the women. We're not different in every instance. But then we look at the compounded stigma. Again, these are gender stereotypes. Men can't be raped. Men should be strong, and those unhelpful attitudes. The other, and this is very important, is that while Don't Ask, Don't Tell doesn't exist anymore, when it did, it was that a homosexual act or statement would be telling, and therefore someone could be separated involuntarily from the military because of homosexual conduct. This has happened in many cases where, because a man is raped by another man, that is considered a homosexual act, and therefore they're kicked out under Don't Ask, Don't Tell. And this happens not only to the survivor, the man who experienced the sexual trauma might be straight, might be gay, but they are accused of engaging in a homosexual act and kicked out. So you can understand that that experience would make someone very, very reticent to report or seek out any kind of care. So trauma-informed care, again, when we talk about the community and what we should all do to improve it, we need to continue defining the evolving needs. This is a population, well, women veterans is a population that will continue to grow. I think that because of the strides being taken with regard to military sexual trauma, that hopefully people will report sooner and in more instances as we continue to struggle in our communities and our work to make that more comfortable for them to do, safer for them to do. So we need to really have an intentional look at this population. We also really need to increase the linkages and referral systems between the civilian and the military or veteran systems of care. There are things that all of us can do. When we do them together, we're much more effective. And the other is applying culturally informed practices. I just want to say that in addition to this webinar that we're doing today, we have a number of curricula regarding cultural competency and specific areas of service. We also encourage you, when you do the evaluation at the end of this webinar, to make suggestions of what you'd like to learn about, what you'd like to learn more about, and of course you can email us anytime and make suggestions as well. Okay, so if you are a non-veteran provider but you want to serve veterans, or you are realizing that you're serving veterans, you want to do it better, first step is IDing clients as veterans. When we were first starting to do work with interpersonal violence, some of our partners in that community started to ask, have you served in the military? Has anyone in your family served in the military? And both Casa de la Raza and our own staff were fairly surprised at the high numbers, but they simply weren't asking. And the other thing is whether you're asking in the correct way, saying, have you served in the military, rather than are you a veteran? We also have some materials about screening. You can look on our website here at Swords to Plowshares, or send us an email and we'll be happy to send you those materials. In addition, the outreach, the language. Are you calling for veterans to come to see you? Well, if people don't identify as a veteran, they're not going to come to see you. So thinking about your signage, your ads, your social media, and what kind of outreach language you're using. The other is peer models are extremely effective with the veteran community. Other communities as well, but we have found that they are extremely, extremely effective. So some of our grantees and partners in Southern California, community service programs, which did Project Her, we had a little case study from them, Working Wardrobes down in Southern California, who were not military or veteran-specific organizations, but in conjunction with their programs to serve women veterans, they both created peer models. So a woman veteran staff, some sort of service or gathering that was women veterans only, and found it very, very, very effective in establishing trust and getting to the hard work of improving these veterans' lives. And the same could be said for male survivors and veterans generally. And again, partnering, veteran-specific and non-veteran-specific entities. Also, Project HER down in Southern California, they partnered very closely with U.S. vets. So we can really help each other, and it's worth doing. Also talking about the continuing need, we've said before, many men and women veterans do not get care from the VA. We know that they will be getting care on the community-based system of care, through primary health care. They're going to be out there, and we should be ready to receive them and to provide them the most effective care and the most culturally competent care. And again, these collaborative models really will help. I want to talk a little bit about language, separating the trauma from the veteran. We talked before, Star said, people asking, do you have MST? And that it is an experience and not a diagnosis. I also want to talk about the word victim for a moment. Trauma survivors, be it military sexual trauma, male, female, the word victim is a word that is not helpful with most people who have experienced trauma, sexual trauma. Prefer to use the word survivor or someone who has experienced military sexual trauma or has experienced rape. There's also a little cultural wrinkle with regard to veterans and military in that being a victim is completely counter to being a warrior, being strong, being a survivor, being a victor rather than a victim. So steer clear of that word. We do use it in some of these slides and some slides coming up because they are in the titles of programs like the California Victims Resources. But when you're engaging in the community and with your clients, steer clear of it. Other military sexual trauma treatment considerations. Touch, gender of the provider, hierarchical environments. Now this again is something that I think is a special wrinkle for military sexual trauma and veterans experience because of the environment they came out of, because perhaps the perpetrator was a superior officer or they had to report to a superior officer who perhaps was not understanding or in fact punished the veteran who had experienced trauma rather than protecting them. So there are levels that are very specific to this community which it's in your interest to understand so that you can really have more of an appropriate approach in treating your clients who have experienced military sexual trauma. So consider your program content, your environment. This again, promoting a sense of control and autonomy. Again, the complete control when people are in the military, they are under the control of the military in a profound way. And so, trying to promote a sense of control and autonomy is very effective. So considering the veteran's trauma history, what effect that's having on their behavior, the role that feelings of helplessness, vulnerability, feeling unsafe everywhere and unsafe in an environment that is really supposed to be safe. And that kind of harkens back to the similarities with incest and family violence, where these environments where you should feel safe and you're not. And again, restoring the feelings of control. And then model that behavior and provide really predictable and consistent, respectful interactions. Also avoid any kind of cold handoffs. You want them to be warm. You don't want people to feel like they have to repeat their story again and again to a stranger. and also repeating their story, not only saying what happened, but having to translate the context under which it happened, that it was a commanding officer, that it was their XO, if it were using language that they have to translate. So think about those in providing your service. Again, PTSD as opposed to PTS. The word disorder has stigma. There's been a lot of work in anti-stigmatization efforts to drop that word. I just want to make a point that in the context of helping your assisting your client who is seeking benefits from the VA, they need to have a diagnosis. So they need to have on paper PTSD as listed in the DSM. So just think about that when you're using that term, and in some cases it may be necessary to use it, even though we understand that it can be stigmatizing. All right, well, thank you, and oh, nope, we have a case study. All right, so this is from Verity. This is another organization that we partnered with in our work in California. This project was around women veterans. We were funded to fund organizations that would improve women veterans' health indicators, but veteran men do seek care. We want them to seek care more often, and Verity had this male veteran man who came to them for help. So he introduced himself as a veteran. When he was 21 in the Air Force in Thailand, a group of his comrades gang raped him. He says that he only recently began to talk about this with his therapist and close family members. He mentions that his daughter was recently sexually assaulted at her college, and that is bringing back painful memories for him. He wants to know how he can support her and what resources are available to both of them, respectively. And now Star is going to put up the poll question, as she did before.
Thank you, Amy. Poll question. What is this veteran experiencing? Possible undiagnosed mental health issues? Reluctance to seek care? New trauma triggers an old trauma? A need for civilian and veteran family services? Or all of the above? All right, with 50% posting their poll, we see that most, 69%, said all of the above. But it was interesting to note that that 31% of you identified that new trauma has triggered the old trauma. All right, back to you.
Okay. All right. I also want to just, in looking at this case study, point out he's 65 years old. This happened when he was 21. So again, these delays in reporting can be decades and decades. And then going back to Linda's material about how you look at those markers and dig up stories of the changes in his behavior. When he was 21, he's now 65. So it's not only telling stories based on people's witnessing, his family, his roommates, but you may have to go digging into research and evidence and stories from many, many, many years ago. And then also talking about the resources in the community. He's looking for resources for his daughter, needing resources for himself, so that community system of care is so important. And now we're going to turn it back over to Lindsay Sin, who will talk about the benefits and services available to veterans.
Thank you, Amy. This is Colleen again. Lindsay will jump back into to discuss benefits, as Amy mentioned, and she'll also be joined by Renee Andreasen and Electa Williams. Renee is a licensed clinical social worker and the Women Veterans Program Manager for the Greater Los Angeles Healthcare System for the VA. In her role as Women Veterans Program Manager, Renee is responsible for leading and coordinating access to health care services for women veterans, and she executes comprehensive planning for women's health issues that improves the overall quality of care provided to women veterans. Renee collaborates with primary care leadership and providers to ensure that the needs of women veterans are met in a comprehensive manner and partners with the VA programs and community programs to help identify unmet needs of women veterans. Electa Williams is a rating veteran service representative with the Department of Veterans Affairs in the LA regional office. Her primary duties consist of serving as a rating veteran service representative on the appeals team. Her secondary duty of responsibility includes serving as the alternate women veterans and military sexual trauma coordinator for the LA regional office. Electa retired from the United States Army as a sergeant first class in June 2009 after 22 years of service. Her combat duty assignments included Balad, Iraq from March 2003 to March 2004 and Kandahar, Afghanistan from March 2005 to February 2006. She was awarded the Meritorious Service Medal, the Humanitarian Service Medal, the Bronze Star, and the Combat Action Badge. Let's welcome Lindsay, Renee, and Electa.
Colleen, thank you so much. This is Lindsay Sin, and I will kick this portion of the presentation off, asking Renee and Electa to join us. Just to clarify, because there are so many acronyms for those of you not familiar with navigating the systems that exist at the federal and state level, I work for the California Department of Veterans Affairs. Renee and Electa are with the U.S. Department of Veterans Affairs at the federal levels. Renee works in the what's called the Veterans Health Administration side of USDVA, and Electa works on the Veterans Benefit side of the USDVA. So we would like to give you all some information about the different benefits that may be available to veteran clients of yours, in addition to, at the state and federal levels, in addition to helping you understand what kind of is available, not just benefits-wise, but within the systems that veterans are navigating. This gives you more clear indications about how that's worked out, in addition to some resources that may be available to your clients. So this is what we'll cover. A couple of the USDVA programs, Renee and Electa will cover that, and then I will cover the California Victim Compensation Program and legislation passed this last year. I will cover my agency, California Department of Veterans Affairs, and I will also provide a slide for the California Military Department, which covers the California National Guard, both Air and Army National Guards. So with that, I'd like to introduce Renee Andreasen to speak a little bit about the Veterans Health Administration and what her role is as the Women Veterans Program Manager. And Renee, I will manage your slides, so just let me know if you want to go slide forward or back.
Okay, thank you. Thank you for having me, everybody. I'm going to address the MST support and what's available at the VA. The VA provides support for all treatment, physical and mental health conditions, free of charge. And as we've talked about with MST, there's various physical symptoms that go along with that, as well as mental health conditions. There is no time limit on how long you can receive these services. Also, you do not have to be health care eligible. You can be other than eligible or have a dishonorable, and you can still receive these services free of charge. You also do not have to have any type of documentation stating that you have military sexual trauma. As far as a military sexual trauma coordinator, it's central office mandated that every VA healthcare system has one, and a contact person, and that person is to be known by all the facilities and available, and that person helps coordinate and assist survivors and staff with any issues related to military sexual trauma, helps get and coordinate services, can walk the veterans through, which could be difficult situations at the VA, and get them right into the services and the programs that they need. Next slide. Full-time Women's Veteran Program Manager, that also is a central office mandated program. Each medical center has to have one. they're designated and advised to advocate for women veterans, coordinates care among primary and specialty care, does outreach. We put on events for the women, try to look at barriers and why the women are not using VA services, make the VA more welcoming, and look at things that might be causing the women to not want to come in for services. Mental health, every VA healthcare facility has providers that are knowledgeable about treatment for MST. All mental health providers and primary care providers are mandated to take courses on military sexual trauma. There's also all types of other kind of trainings that are available throughout the year for those that want to continue and maybe specialize specifically in that type of training. We also work with the vet centers very closely. They also provide sexual trauma counselors. A lot of time we find that women or men who might be employed here don't want anyone to know what their past is and will choose to seek out the vet centers. Also, a lot of the VA facilities are large and the vet centers are a lot smaller and a more intimate kind of setting. The VA has over 20 programs nationwide that offer specialized treatment in residential and inpatient settings. There is also a VA website that is specifically designed for military sexual trauma, and it lists out everything that is available and contacts. It also gives the facilities and the CBOCs and the vet centers for people to go. Next slide. These are the crisis lines. You have the veteran crisis line, and then there's a specific one for the Women's Veteran Call Center. The Veterans Crisis Line is 24 hours a day, and there's a clinician that will get back to whoever calls within 24 hours. The Women's Veteran Call Center line goes to the Women's Veteran Program Manager, and we get back to them and guide them through the system and help them with the issues that they're calling about. Next slide.
Okay, thank you so much, Renee. That's helpful information for all of you who may have clients that are seeking services or want to seek services through the Veterans Health Administration, the most important points of which are that MST healthcare and mental health care services are free of charge, are unlimited in duration, and do not require the individual to have a service-connected disability at the time. And so they really do have a great deal of access to services related to their assault or experience from VA. So now I'd like to ask Electa Williams to talk a little bit about the Veterans Benefit Administration and what she's doing as well. So Electa, I'll turn it over to you, and I will also manage your slides.
Thank you, Lindsay. Greetings all, and thank you for having me. The Women's Veterans Coordinators are located at each and every VA regional office across the nation. The Women Veterans Coordination function as a primary contact for women veterans. During this contact, women veterans are provided the highest quality of assistance and also offer privacy, dignity, and sensitivity toward gender-specific needs. Being the primary contact for women veteran coordinators are also provided specific information and comprehension assistance on VA benefits and related non-VA benefits. The same information assistance is always extended out to the veteran's dependents and or beneficiaries. In regards to the military, sexual, and personal trauma claims, women veteran coordinators assist with the intake, the development, and processing of evidence in support of these claims. Veteran service representatives are trained on addressing military sexual trauma claims. The training for a VSR, which is a veteran service representative, develops the evidence, and they also assist with the evidence from the veteran in retrieving, they also assist the veteran in retrieving the evidence in support of their military sexual trauma claims. Once the development process has been completed, the claim is then forwarded to the rating veteran service representative, or the RVSR. A trained RVSR will then review, evaluate, and determine where the service connection is warranted based on the evidence of record. And the evidence that I'm speaking about is the evidence that Linda spoke about earlier. Not only are veteran service representatives and rating veteran service representatives are trained on the proficiency of handling the MST claims, but the training also consists of handling claims with sensitivity and compassion. Thank you, Lindsay. Next slide.
Okay. Oh, did I not? Sorry. Sorry, folks. Okay. Thank you very much, Electa. So the important thing to note here is that when a client is looking to file a claim for military sexual trauma with USDVA, if they're in the course of your work with them indicating that they are unsure about how to do that or that they don't have a great deal of faith in the system or program, it's really important to reassure them that that there are folks at the regional offices. There are 3 regional offices here in California, which are Oakland, Los Angeles, and San Diego. There are women veteran coordinators at each of those offices, so there are direct points of contact that are handling those claims. They're also the last person to review the claim. If the claim is looking like it will be denied, they go back through the claim to find out if there's any other markers or evidence that could be used to support their case. In my experience in working directly with Linda Benoit and other women veteran coordinators, they really can look into a claim and comb through it and find more information for those veterans. They tend to be very compassionate people and understand what these survivors are going through and how difficult it is to submit a claim. Some things to note with the claims development process. Oftentimes when a veteran is submitting a claim for MST, they are asked to, well, they're always asked to fill out a stressor statement. Something that Linda may have mentioned in her talk is that it's a very small space that the stressor statement form is actually consists of, but veterans are always welcome to provide additional evidence and use a full piece of paper or as many pieces of paper as they want to actually write that stressor statement. That stressor statement would basically be a documentation of what happened to them, what incident occurred, where they were, when it happened, and the details related to it. This can be a very stressful situation for veterans to go through, having to recall any incident that happened to them in the military that has caused trauma. And so we really encourage our veterans to find a safe space to do that in. If they need to sit down with a counselor to discuss that before and after, that they're perfectly welcome to do that. We want to ensure that whatever evidence they're needing to provide and how they have to relive that situation or experience in order to submit a claim for compensation, that they're emotionally supported to do so. And I think that's where a lot of your offices are key in this situation. Offering them the opportunity and the space to do that, to file that claim, well, to fill out that stressor statement in support of filing that claim in a safe space is really key to helping and supporting a veteran that you may be serving as one of your clients. Additionally, we also see that when someone is unfortunately denied a compensation claim, which is often the case because of the burden of proof and evidence needed to substantiate a claim, it can re-trigger individuals. It can cause a great deal of anxiety and depression and essentially re-traumatizes people. And so when you're working with a client, just as I have seen in my role here, and I think a lot of our presenters have seen, you may encounter somebody that already has been denied a claim for compensation. And this is a really difficult experience for them to go through. They are extremely depressed about it. They may be suicidal over it. And they may be seeking services because all of this denial has actually caused more trauma to resurface. So please be aware that that may be the case. If you're asking about whether or not your client has accessed VA benefits and resources, do so with a sensitive approach, because just as Star had mentioned in her portion of the presentation earlier, when we discussed that case study about a woman becoming defensive or combative about being thanked for her service. When you're asking someone if they've worked with the U.S. Department of Veterans Affairs on a claim, for instance, or sought health care there, that needs to be approached with a great deal of sensitivity, because that individual may have been rejected for services or for compensation claim at some point, and may have a lot of resentment and anger about it. So be sensitive with that approach as well. So I'd like to talk a little bit about the California Victims Compensation Program. California Victims Compensation Program is a state organization that provides restitution to victims of crime, and this is anything from crime related to personal crime, assault, robbery. They can provide all sorts of restitution to approved cases having to do with resources given for loss of income, for mental health resources, for healthcare needs as well. So last year, Bonnie Lowenthal, a former assembly member in the California legislature, authored and successfully passed, and it was successfully signed by the governor, Bill AB 2535. This really allows anybody who is a survivor of military sexual assault and a resident of California to apply for funds of restitution, specifically for mental health support, through the Victims Compensation Program. So previously there was a barrier there where individuals had to have a documented case of an assault or a crime in order to apply for the funds. That barrier has since been removed because of AB 2545, and now any victim of military sexual assault that that is a California resident, that was in the military at the time of the assault, whose perpetrator was also in the military, they can now seek some restitution funds or can apply for those funds. This is effective as of January of this year, but the incident itself can have occurred in the last 3 years. The documentation that will be required, we're still working out with CalVCP what guidelines will specifically need to be in place to take in these applications going forward. But there will be some documentation, such as a military record of service, that may help to establish that the person served in the military or is serving, or an ID or something like that. But this is a good step towards helping to support the mental health needs of our survivors in California. Because unfortunately, by the time we and all of our organizations see a veteran, you know, we're all picking up the pieces from a terrible violent crime that happened to them. And our first priority is to make sure that they're doing well, and that we can address any issues, health and mental health, that they may have. So this is one step in that direction. So to tell you a little bit about the California Department of Veterans Affairs, which is my agency, our mission is to serve our California veterans and their families. We provide several different benefits. We not only administer state benefits to our veterans, which include representation for filing claims for disability compensation or other types of claims with the U.S. Department of Veterans Affairs. But it also includes the CalVet Home Loan Program, where we offer home loans to veterans that qualify. We also have long-term housing for our aged and disabled veterans. We have 8 homes throughout the state of California with different levels of care for them. And then we also act greatly in the advocacy role for our veterans. My office specifically represents Women Veterans Affairs, and we focus on targeted and outreach and programs to women veterans, as well as providing advocacy for their needs and some challenges they may have, and raising awareness that women do in fact serve in the military. And so over the last year and a half, we've really focused on military sexual assault and how we can better support our survivors here in California. And these are some of the goals that we have with that. The first is that we want to see the percent of claims filed for our California veterans for anything related to military sexual trauma. We want to see that those are awarded at greater percentages. Unfortunately, there was a nationwide, there was an ACLU and Service Women Action Network filed a lawsuit against the U.S. Department of Veterans Affairs in order to gain access to public records. And those public records showed that 2 out of 3 claims for military sexual trauma-related issues were rejected by U.S. Department of Veterans Affairs from 2008 to, I believe, 2011. So these claims related to military sexual trauma tend to be underawarded, and that has to do with the burden of proof for evidence. Now, that has changed recently, as Linda was indicating and Alexa touched on. The claims process has changed a bit for MST related claims, so that less evidence is required, but it still remains a challenge. And so really, as service providers, one thing you can do is help your clients document what they're receiving counseling for. If it was a sexual assault in the military and they may want to file a claim at some point, all the documentation that you can help them with is going to help make their claim stronger. We additionally really look at, with this initiative, some of the laws and policies that really need to be changed at the different levels, local, state, and federal levels, to support survivors. That includes providing technical assistance on California legislation, and we've done that with AB 2545 and a few other bills on this docket for this year. We also correspond with federal legislators and their bills that they may be looking to submit. For instance, Congresswoman Jackie Speier from California here has submitted a bill called the Military Track Act, which is making its way through the houses right now, and that would allow DOD to establish jurisdiction in order to track military sex offenders, which is something they don't currently have the ability to do. So the hope is that if this passes, DOD will be directed to and will create a database that tracks military sex offenders. That will go a long way with ensuring that people are not coming out of the service as perpetrators and being kind of lost in the general population of the American public, which does happen. Additionally, we also take a lot of phone calls and emails from women who have served, from widows that have served, from family members, and we connect them with resources and assistance where we can. So people call about housing needs, financial support needs, they call about benefits and claims, they call about all sorts of needs that they may have, and we do what we can to provide greater support for them. And so that's a little bit about our department. A few more notes I want to give to you all regarding this. There are a lot of resources for where clients can seek services with U.S. Department of Veterans Affairs at va.gov on the web. You're also welcome to contact our office anytime if you're looking for resources for your clients, and that can be through women veterans, plural, women veterans, at calvet.ca.gov. And we're happy to provide all of our contact information if we can. A couple other things to note. If you want more cultural competency related to women who have served in the military, we have released a Women Veterans Outreach Toolkit. This is a guide that explains some of the unique characteristics of service of women who in the military. It talks a little bit about needs and challenges that women have. It also gives a great list of action items and a to-do list that you as an organization or an individual can undertake to better outreach to and serve women who've served in the military. You can find all of that information on our website. That's calvet.ca.gov/women veterans. And that is our Women Veterans Outreach Toolkit. We have also worked with the California Association of County Veteran Service Officers to develop outreach brochures about military sexual trauma that they will deliver and that we can deliver to their clients and to your clients. And so this brochure lists some interesting information about military sexual trauma, who can apply for benefits, what benefits may be available through that, and what support services are out there. And it also has a great list of links on the back of the brochure. So if you're interested in getting any of those brochures, we can help provide them. I have a box in my office, and if you contact us at Women Veterans, we'd be happy to provide that to you. So with that, I'm going to turn it over to one last resource for you. If you're working with a client who's been serving in the California National Guard, then they have resources available to them, specifically through their Sexual Assault Prevention and Response Program, otherwise known as the SAPRO program. This website, along with the DoD Safe Helpline shown on the screen, is where individuals can seek services through that office if they need to report a sexual assault while serving in the Guard here in California. And so the California Military Department is the department that covers all of the California Air National and California Army National Guards. So now I'm going to turn this back over to Colleen and Star to cover a little bit about some resources available via the web, as well as go over questions and answer a portion of the webinar. Thank you.
Thank you, Lindsay. So Star can go through some of the resources here towards the end of the presentation, and then we'll start some questions.
Thank you again, Colleen. We're going to, all right, some of the additional resources that are relevant to the topic of military sexual trauma and sexual assaults. We've got Protect Our Defenders, the Service Women's Action Network, the Battered Women's Justice Project, Rape, Abuse, and Incest National Network, RAIN. So all of these resources were in the PowerPoint presentation that you received via email, or you can always contact us at a later time to make sure that we connect you with individuals within the organization if you need so. Verity, Community Services Program, Inc., Project HER. We saw 2 of our case studies that came straight from them, Legal Aid Society, Employment Law Center, and Work and Family Hotlines. All right, and at this time, Colleen and Megan will do our question and answer portion.
Thank you, Star, and thank you to all of our presenters today. We'd like to open it up for questions and discussion with the audience. If you have any questions, please feel free to ask them by using the chat box or question box on the right-hand side of your screen, and we're going to do our best to get through all the questions. We've already answered some through the chat feature and have identified some that are a little bit more complex that our presenters can address. If you've asked a question at any time, we'll address what we can. So, and right here we have some prompt questions for discussion for you. So let's get started with a couple of the first questions. First one here we've got is a question for any of the presenters can chime in. One participant asked if we could talk about the addition to the DSM-5, specifically Criteria D and Criteria E, which talks about blame, shame, and reckless behavior. How has this changed the clusters, and how does this present in veterans with military sexual trauma, or as we've learned before, who have experienced military sexual trauma? It seems many service providers are unfamiliar with ADA regulations and needs of those with a disability, including safety needs required for any significant recovery from MST for MST survivors or those with post-traumatic stress disorder as a result of the MST. Is this correct? So I'll let the presenters chime into this question. Once again, it started with the recent addition to the DSM-5, specifically Criteria D and E, which talks about blame, shame, and reckless behavior. Thanks. Perhaps we can, Linda, could you address this question since none of our presenters are chiming in just yet?
Yes.
Thank you, Linda.
Specifically, would you rephrase that for me, please?
Sure. The participant asked if you could talk about the addition to the DSM-5, specifically Criteria D and E, which talks about blame, shame, and reckless behavior. How has this changed the clusters, and how this presents in veterans who've experienced military sexual trauma?
That is very vague. I don't understand the question, to be honest.
Okay, well, could you speak about whether or not, your opinion? This participant said that it seems as though many service providers are unfamiliar with the regulations under ADA and needs of those with disabilities,
Okay. Well,
and the safety requirements needed.
Okay. When we talk about developing claims for PTSD due to military sexual trauma, and as Lindsay alluded to as well, whenever I would, and still whenever I interview young men and women or older men and women, whatever the case may be, I always advise them that this is your story, this is your history, no one else has experienced it. And you need to advocate, number one, for yourself. You need to write a statement detailing how it has affected you, because nobody else can say how it has affected them other than the survivor themselves. And sometimes survivors will say, will you help me write it? No, you can't help someone write their own story, no matter how grammatically incorrect it may be, no matter how many misspelled words there may be. It has to be their story. And as Lindsay said as well, it's going to be painful, it's going to be brutal, but it has to be done. And when it's done in that fashion and it's presented to the Department of Veteran Affairs as part of the evidence, it goes a long way, especially when there is no report of this event happening.
Okay, thanks, Linda. So this is Lindsay. I want to go back and address this question a little bit. So just as Linda's indicating, for when you're working with clients that are wanting to fill out a claim, for instance, then those are really important points to make to them. But when you're working with clients, or if you are a clinician and asking these questions, then that's a little bit of a different approach. You're clearly referring to the Diagnostic and Statistical Manual of Mental Disorders. Sounds like there's been some updates to that. Most of us who presented are not clinicians, so I would actually want to ask Renee what type of training the VA healthcare side of the house is getting on any updates to diagnoses or behavioral expressions related to trauma. Renee, can you indicate how often people are getting training, or if you're aware of any sort of updates that they get based on mental disorders and how those are updated in the DSM-5?
So in general, to keep your license, I mean, you keep up on the training. We did get training on the DSM-5 specifically. Also, the VA has the PTSD National Center for PTSD, which goes into the DSM-5 criteria for PTSD, and it lists all the criteria all the way through. So if the person would like to get on there, they can look at each thing that qualifies.
This is Amy, and we can also, while this presentation, as Star said at the beginning, is meant to be an overview, we could go into and have 3 hours on any specific element of this, and we certainly are open to doing a follow-up that would have some clinical experts that could address those subjects.
Do we have any other comments from the presenters, or should we move on? Okay, I'll take that as a move on.
I think we should move on, Colleen.
Okay. The next question is somebody wrote in mentioning that, we've talked a lot about our current generation of veterans and have not talked about the Vietnam era. MST is a relatively new issue coming to the forefront in the world of the Department of Veterans Affairs and military as far as addressing it and reporting. What is suggested for older veterans who never reported a violation or incident, particularly because there were no paper trails or evidence? Thoughts on this?
This is Linda. I'll take that question. As I said in my presentation, when a veteran has experienced an event such as military sexual trauma, no matter what era they served in, it could be World War II, Korea, Vietnam, Gulf War, current conflicts now, it is never too late to file a claim. There is no time limit for them to file a claim. All they have to do is be proactive and go to providers such as Disabled American Veterans, Military Order of Purple Heart, your county VSOs. Any of these service organizations can assist the veteran in filing a claim. However, as I said before, writing their own statement, that's, no one can write a statement for them but the survivor themselves. There is no time limit. All they have to do is take the initiative and file a claim.
Okay, great. Thank you, Linda. This next question is going to be directed to Amy and Star. So one of the participants says, we mentioned in our presentation that 76% of women veterans don't seek or receive VA care, and 72% of men. Can you speak to the reported instances of re-traumatization that veterans report in navigating the VA system? Many women MST survivors report being invalidated by not being considered a veteran. Also, our participant has heard veterans complain about the way they've been responded to when calling the crisis lines and being re-traumatized by those interactions. All these things make it more difficult for survivors to seek care and benefits. What are your suggestions about addressing these concerns and how to best encourage these survivors to persevere in receiving the support and care they need and deserve? Amy?
I would actually, yes, this is Amy. I would actually defer to Megan, who is our data woman, whether there has been, data collected on that. We do know anecdotally that this is a problem, that women go and they feel that it's not a safe environment, that it's a, that they're being checked out, to use the term. So we know that this is a problem, but we need to collect more hard data on it. And then also, in the meantime, we just have to make sure that our voices are heard, to make sure that staff are trained. Also, whether it's the VA or in your own agencies, not only make sure that your staff are trained, but make sure that your clients behave. Many of the clients at a veteran-specific agency may be men and may inadvertently create a difficult environment. So, Star, do you have anything to say?
Yes, thank you, Amy. One of the things is that response to the increased numbers of those who are coming forward to seek care, services, and file claims are continuously changing and growing. And so 10 years ago, there wouldn't have been very many conversations at all about sexual assaults other than in a few printed material and some publications. But we're talking about it. There's a lot more advocacy and there's a lot more emphasis ensuring that not only are we providing the culturally competent care, understanding what the experience is, but we're also ensuring that our rules, regulations, laws are supporting those who are really trying to impact change. So I think that change takes time, and I like to think that things are going in the right direction. And I think that, those who, if there's any one of the panelists that want to chime in, that in the Vietnam era and or post-Vietnam era, it was a completely different environment if you wanted to seek care and services for sexual assault. So as Amy said, finding more data and finding ways to collect this information. Lindsay, the California Department of Veteran Affairs, has done surveys. Swords to Plowshares has done surveys. Large institutions and educational institutions have done surveys to really try to collect that data. But until we have more and we can identify the areas that need the continued education, that need some cultural competency training, that could benefit from trainings like this, it's hard to make sure that someone who is a survivor coming forward 3 years from now or 30 years from now will continue to get better care than those who came forward 20 years ago or that have come forward recently.
Thank you, Star. Let's move on to the next question or comment. The Military Outreach USA works with houses of worship across the country, and they've found that the faith-based community can be great supporters of those affected by military sexual trauma. At Swords to Plowshares, we've certainly seen the same thing, that faith-based communities are often the first point of contact for women veterans and military sexual trauma survivors whose trauma may be triggered, as we mentioned before, by going to veteran-specific services. Star, can you talk about this, please?
Can you clarify the question?
Sure. As far as your experience with the fact that faith-based community organizations are often the first point of contact for those affected by MST and for women vets. Any comments there?
Yes, I think that the faith-based community has really stepped up because they realize that they, are a place that is comfortable to those who have experienced trauma before they join the military, and when they're not able to really find that sense of calmness and that sense of peace or the sense of community that they are seeking. Most importantly, women, but those who have experienced trauma and those that are trying to come to grips and find coping mechanisms, we find that there is a tremendous number that are seeking their faith-based community to get that acknowledgement, that recognition, get the support and encouragement. And the faith-based community is responding, particularly in the Bay Area. I've actually received calls from as far away as New York. And we talked very briefly in the very beginning about the concept of moral injury. And the faith-based community has really responded to trying to understand moral injury and helping veterans and service members learn about their experiences and how the fact that they are a little bit different now than when they joined the military, and that the community can really be the support system that is outside of the hierarchical structure that can often be re-traumatizing. So I think that the more that community continues to bind together and they continue to do retreats and educate the congregation about how they can support those that are coming to seek and support outside of the areas where we see a lot of community support, such as Memorial Day and sometimes on Veterans Day. But having the faith-based community do, much more smaller groups, smaller group discussions and panels, and finding more ways to engage with the congregation. And I'm definitely seeing a strong amount of that faith-based community trying to find out what they can do to help.
Great, thanks, Star. Let's segue real quick into a similar question about MST group facilitation classes that we might be aware of within California or nationally that help prepare MST survivors to be a peer supporter, since we're sort of talking about the outside the VA sphere or veteran-specific service providers. What resources might be available to help people become peer supporters? Is anybody aware of any MST group facilitation classes?
Well, this is Lindsay. That's a great question. There are obviously several support classes that are run throughout the state, either at VA vet centers in the communities or through the local VA hospitals. In terms of peer support to focus on people becoming, I guess you could say, advocates for MST survivors. There are a couple national organizations that do that, and that can be, I think, accomplished online. That can be advocacy accomplished online. I think Protect Our Defenders has something like that. There's another organization whose name currently escapes me, but I can follow up with this question and get some answers if our participant can email women veterans at calvet.ca.gov, I will find the contact for that. But additionally, there are peer support networks going on for women veterans, not specifically related to MST, but those are happening throughout the state. I know STAR can talk about their peer network group and a couple others that are going on. STAR, did you want to talk about SWORD's peer mentor net group for women?
Yes, thank you, Lindsay.
Before we start, I just wanted to remind you all that we have just 20 minutes left and several other really detailed questions, so if you can keep it brief.
Thank you, Colleen. The Women Veterans Professional Network is really focused on peer mentorship that is geared towards employment, so it's a little bit of a different focus. However, I do know that the vet centers have kind of an internal network where someone comes, they start to seek services through their group and their peer mentoring program, and the idea is that they will at some point lead that group and then graduate more outside of that group and you know, really try to engage more with veterans outside of that system of care. But I can certainly, just like Lindsay said, do some more research and identify some other areas where there's either the vets to vets training model or some other training models that focus just on sexual assault.
Okay, awesome, Star. This is Lindsay again. I think I found it. Check out militaryrapecrisiscenter.org. This is a group based in Phoenix, I believe, but I think they have advocacy training. I recall they did at one time. So militaryrapecrisiscenter.org is a resource. Also check out SWAN. Okay.
No, that's okay. You have another resource?
Just check out SWAN, Service Women's Action Network, and Protect Our Defenders as well.
Great. And hopefully we can include some of these resources in the follow-up emails as well, to reiterate. So let's move on to some questions about VA disability claims. I'm going to direct this first one to Electa or Linda. And the question is, aren't veterans better off filing a disability claim through a Veterans Service Office as opposed to a fast-track claim? One mistake, and there can be endless problems, which is the case, as many of us know, if the claim is not fully developed. It is also important to know that the Veterans Benefits Administration is different than the Veterans Health side, yes, of course. Many veterans are confused when they hear claims backlog when that has nothing to do with getting their medications and other basic needs. Electa or Linda, can you address this, please?
So I'm sorry, can you repeat your question? I was trying to understand. I had a little delay in the back.
Sure. The question began with, aren't veterans better off filing a disability claim through a Veterans Service Organization as opposed to a fast-track claim because of the fact that, you know, one mistake and there can be endless problems with the claim? Let's start with that part of the question.
Okay, veterans have the option. They can either go through a Veterans Service Organization, or they can either go through the e-benefits website. Either or, the veteran has that option. If he or she feels better and they are computer savvy, then we always try to encourage the veteran to go through the e-benefits side of the house, mainly because they are able to track the status of their claims. They can also, if they're not computer savvy or they feel more comfortable with going through the Veterans Service Organization, then they have that option also. Neither way is a delay, but they're both good options. Did that answer your question?
Sure, thank you, Linda. I'm just going to chime in because I wanted
Colleen,
to share that.
Lindsay.
Sure, go ahead.
Thanks, Colleen. Thank you for answering some of that, Electa. Now, Electa works for the Veterans Benefit Administration, and they do have two options. Like she said, there's e-benefits, and then there's also organizations that directly liaise with the federal VBA in order to file a claim. My personal opinion, Lindsay, Calvet, yeah, file it with the Veterans Service Organization because the claims process is incredibly difficult and a legal process, and yes, there can be mistakes made. So we would encourage people to file it with the county veteran service officer. If they're comfortable filing with a veteran service organization that's not the county, they always have that resource available. If you go to a VA hospital, individuals are there actually representing one of those VSOs, and you can file a claim at the VA hospital with one of those reps. The most important thing, though, is that a veteran needs to be their own advocate in a lot of ways. They need to make sure that they have all their documentation, that they are going to be of the right sound mind to fight for their own case, that they're also going to have that support network that you all can provide when things are not going as well as they could. That means that they also need to advocate with the VSO. If the VSO is not providing what they want them to provide, if they're not feeling like their needs are being met, then they need to explore other options. But ultimately, I think it's a good idea to seek out a veteran service organization or county veteran service officer to do the claim. I had to give my 2 cents.
Oh, I agree. That's exactly what I was going to say, Lindsay. Fully developed claims are extremely important. And Swords to Plowshares has some drop-in hours for legal clinics and self-help guides on our website, and hopefully we can follow up with those resources. So let's move on to the next one about post-traumatic stress. So this one is again directed to Electa or Linda. Does PTSD have the same access as MST as as far as rating? You know, what are the differences as far as a rating from the VBA with regard to PTSD and MST?
Well, there isn't a difference with the rating. All psychiatric conditions fall up under 38 CFR 4th part, what we use with rating the psychiatric conditions. So MST is the event, but the diagnosis is what we look for. And it's not only applying to PTSD, but according to what someone mentioned earlier, the DSM-5, we have different diagnoses that could fall into that category.
So I would just clarify that you are not getting rated for military sexual trauma. You are getting rated for post-traumatic stress that is a result of military sexual trauma.
That would be correct. Yes, ma'am.
Yeah.
Correct.
Thank you, Amy. Thank you, Linda, as well. Okay, let's move on to a couple questions about reporting. I just want to state in advance that I asked all the participants to understand that although we've covered the reporting process and disciplinary action, our emphasis through this training is covering information on veteran survivors after their service, when they access services and benefits from the VA and from within the community. So we might not be able to answer some of the specifics related to the military process, but please keep these great questions in mind for further trainings on military sexual trauma. So let's start with one question for Lindsay or Linda. Are there steps that survivors can take with regard to reporting, pressing charges on a sexual assault during a tour of duty, let's say 10 or 20 years after the victim has been discharged from the military? And also how, and are now, and that they now have the courage to report or charge the perpetrator to reach the closer. So let me repeat that again. What are the steps survivors can take in reporting and pressing charges on a sexual assault that took place during a tour of duty 10, 20 years ago?
Well, that's a really good question. I'm hoping that perhaps we have other attendees on here that are more focused on that legal services side of the house that we can follow up with an answer for this person. As far as I know, there are not a great deal of legal kind of follow-ups or procedures that can aid that survivor pressing charges. It may all come down to the statute of limitations. And so if the statute of limitations for filing a claim of rape is passed in the civilian side, I don't know that it would be too different in the military side. They may have real trouble finding and tracking that person down because the military is pretty protective of its members in terms of their records and privacy. I don't know that they would be helpful in getting a location on that individual. It may be something that would require a charge of an assault or rape with local law enforcement for them to open an investigation to see if that person's listed in CODIS for a DNA hit or anything like that, if they even had DNA. Some of the challenges with the pursuing justice with the military system is that rape kits, just like they do in the civilian sector, can sit on shelves for years and can go untested for years. But more importantly, in the case of reporting and getting a safe kit done, which also happens within the military system of filing an unrestricted claim, that rape kit's not going to sit on the shelf forever. They may destroy it. For, I think, restricted reports, this may have changed, but I believe safe kits are kept on file for a year and then destroyed if the case is not moved to unrestricted from restricted. Once it's an unrestricted report, technically the kit is supposed to be kept by whomever the local jurisdiction, whether it's local law enforcement or I believe what would be military law enforcement. It's supposed to be kept for 50 years. So it should be available as evidence to prosecute a claim, but I don't know of anyone that's done that successfully in the military system. So it may come down to finding out what the statute of limitations is for sexual assaults in civilian jurisdiction. But I'll see if we can get some more answers for this person. Perhaps they can contact our webinar coordinators, or they can contact women veterans at calvet.ca.gov, and we'll see if we can get you some answers. And hopefully we can get some folks that have dealt with this to chime in as well.
Thank you, Lindsay. So I think these questions might also be for you again, but we can have some other presenters chime in. Why is it that the perpetrators are not moved, and it's always the victim who is or the survivor, as we've learned, is moved? It might be another reason why survivors do not report instances, and because of their location. And
well, and I believe that may have changed too. My understanding is that prior to this recent change, that the survivor could elect to move. It was always the survivor that moved, and now I think they can opt for one or the other to move. So the criticism from the previous system was that it was always the survivor that had to move, and therefore they lost their support network that would kind of help them through this process of the emotional support or financial support they may need. Whereas now I believe they can opt through unrestricted reporting to have the perpetrator moved. I'm not positive, but we can also get some answers on that. I think that that has changed. And yes, that would definitely constitute a barrier, though, because if that person then has to leave their support network or their friends or their family or a job that they really loved, then certainly they would be less likely to report.
Thanks, Lindsay. Also, I mean, if the survivor requests an expedited transfer, how often are those granted?
I couldn't comment on the percentage of how often they're granted. I don't know what type of data the DoD is coalescing on that, so we'd have to look for more data. We can go back to that slide and give a little bit more input, and I can also follow up with some of the SARC coordinators that I know to get more answers. Okay. It would really come down to the commander's discretion, though, I believe.
Okay, thank you, Lindsay. We have a comment from Brian Clubb from the Battered Women's Justice Project, and Brian wrote, for our information, the Uniform Code of Military Justice has an article covering conduct unbecoming of a commissioned officer, but not a general article that applies. Also, non-commissioned officers and junior enlisted service members. So again, the Uniform Code of Military Justice has some conduct codes, but not all. Any comments?
Yeah, this is Lindsay. Thanks for that comment, and yes, that's a good clarification for what I presented earlier. Although there is a UCMJ article that's usually used as a catch-all when it comes to trying to prosecute somebody when they were not able to make a charge, a higher charge of assault or rape stick. I know they use an article, but I don't recall what it is, but that's correct. Conduct unbecoming is for...
That's Article 134, Lindsay, of the UCMJ. That is the general article where it's a catch-all article.
Okay. So I know that's what's used typically. Thank you very much, Linda. Article 134, but that's true. Conduct unbecoming is reserved for officers only.
Okay. If I could just offer another resource, it's a little bit going back to a previous question, but I wanted to offer another resource, which is TAP, which is Trauma Assessment Project. They are out of Portland, Oregon, and they offer trainings for clinicians that are very deep and very specific, We have Elizabeth Stinson, who's with them, is I think the leading expert in the clinical treatment of military sexual trauma. So you can look them up for materials and learning opportunities, particularly for licensed individuals.
What does that acronym stand for again, Amy?
Trauma Assessment Project. And not only clinical treatment, but they also offer support, advocacy support when people are going through claims. So very aware of the interaction between the claims process and the psychological well-being and the treatment of survivors of military sexual assault.
Great, thank you. So we're just about out of time. What we'll do is follow up with some of the more complex questions. And again, we hope that folks will continue to think about the information today and keep in touch and follow up with further questions. Whatever obstacles you're seeing in your own work and what needs to be done to address them. So that'll conclude our presentation for today. Thanks so much to all of our presenters and to all of our participants who listened in on this webinar today. Please note that each of you will be receiving an email in about an hour asking you to complete a brief survey to evaluate today's presentation. Your feedback's very important to us and it's greatly appreciated, so we hope you'll take the time to complete that. Those of you who are seeking continuing education units or certificates of completion will need to complete this information in order to receive credit for participating in today's training. We'll also be archiving this presentation on our YouTube channel. Again, that's at youtube.com/vets helping vets within the next few business days, so you can find that there. Thanks again for your time. This concludes our training, and now you may disconnect from the webinar. Have a nice day.